Hello, everyone. Welcome. Welcome to our second session of our Learning Collaborative. I do see that we still have some participants that are joining. So we're very excited to have you joining us today. Okay, let's get started. So today we're going to present on the second session of our Learning Collaborative on exploring cultural competence and humility in the care of HIV patients. And this presentation today is brought to you by the National Center for Health and Public Housing. And then in today's session, we will be focusing on how to destigmatize HIV. Before we continue, this is just a quick reminder to all participants that are joining that your line is muted upon entry. Please make sure that you also engage in the chat if you have any questions or any comments. We will be doing some activities throughout today's session, so we also encourage you to participate as we ask some questions, or if you have any questions for the speakers for today as well, please make sure that you raise your hand if you'd like your line to be unmuted. And the meeting is also being recorded, and the slides and recording link will be sent to you all via email after today's session. So the mission of the National Center for Health and Public Housing is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. And CHPH is a project supported by the Health Resources and Services Administration and is a national training and technical assistance partner that is 100% financed by this grant. The information presented today are those of the author only. So here we have just, this is just a brief introduction of ourselves. With us, we have Dr. Jose Leon, who is the Chief Medical Officer at the National Center for Health and Public Housing. And myself, my name is Fide Pineda. I am the TTA Manager here at NCHPH. And we're honored to also have our guest speakers, Dr. Adla Tessier. She is the Director of Specialties Clinic at La Maestra Community Health Centers. And we also have Lisa Rowinski, who is the HIV Program Coordinator at DEFCAN Community Advocacy Network. So before we continue, here is some background information about the health centers that were close to public housing, in case you weren't able to join us in the first session. So according to 2022 health center data, there were over 1,300 FQHCs that served to 30.5 million patients. And of those 1,300 FQHCs, 483 FQHCs were in or immediately accessible to public housing that served to 6.1 million patients. And 107 were public housing primary care grantees that served to over 935,000 patients back in 2022. And then in the map to the right, we can see a distribution of these health centers that are located throughout the nation. So here we have some public housing demographics data. This is all data gathered by HUD. And back in 2023, there were over 1.5 million residents. And of those 1.5 million residents, there were 2 persons per household. 91% were low income, 36% were children, 32% were female-headed households with children, 38% were disabled. And in terms of race and ethnicity, 52% were white, 43% were African-American, 26% were Latinx. And that is it for the facts in this slide. So now I will pass it on to Dr. Jose Leon, who will be going over the Learning Collaborative expectations for today.
Thank you, Fide. And hello, everyone. Good afternoon or good morning. I know that we have people from all over the United States, and one of our speakers is in California, for instance. So good morning to all of you who are on the other side of the country. And thank you for being with us one more time. And just This is a quick reminder that this is a learning collaborative, and the expectations are that you participate, that you engage, that you ask questions, that you share your experience, or if you have any promising practice or any evidence-based intervention, please feel free to share with us all the good activities that you're doing to serve your communities and your patients. We have community health centers attending this session. We also have public housing agencies, community organizations, and federal and state organizations as well. So we have a great variety, and I know that you are helping our patients, or you're helping our people to address all the concerns, and not only health concerns, and not only the HIV issues, but any of the issues related to their health. It's really interesting to see one of the slides that that Fide just went over, and specifically the one that is related to people with disabilities living in public housing, which is 38% of those living in public housing have at least one disability. And this is going to be a really good opportunity to hear from Lisa Rowinski as well. She has really good information to share. So please make sure that if you have any question for Dr. Tessier, if you have any question for Lisa, ask those questions. And thank you again for being with us. Next slide, please. The learning objectives for today's sessions are apply the cultural competent intervention in an HIV clinic, or describe culturally appropriate strategies to use in HIV clinic settings, and discuss strategies to destigmatize HIV. Next slide, please. So before we get into our conversation, this is our icebreaker for today's session. So the question is, if you had to eat one meal for the rest of your life, what would it be? Please, you can type your response in the chat box. So let us know what you would like to eat. If there would be just one thing that you have to eat. So Brian says lasagna. That's a really good.
Yeah.
Tacos from Brenda. That's great as well. I love tacos. Lisa, pizza. Excellent. That's beautiful. Quesadillas, Mediterranean food, pupusas, carne asada. Oh my, those are really good options.
I wish I could eat all of that for the rest of my life.
Well, you have to pick one, Fide. So thank you so much for engaging. Next slide, please. So at this moment, I will turn it over to Dr. Adla Tessier. She's been with La Maestra Community Health Centers, and she has 30 years of practice in family medicine and internal medicine, 5 years in a specialty with hepatology, endocrinology, and HIV clinic. She is the director of the specialties clinic at La Maestra, and she is leading the addiction medicine program at La Maestra Community Health Center located in San Diego. So good morning, Dr. Tessier.
Good morning. Thank you very much for this invitation, and to be able to share with you all some of our practice patterns here at our Community Health Center. Next slide, please. So let me tell you a little bit of La Maestra. We are located here in San Diego, and the history is the clinic was formed in 1990 under an amnesty center. The need for culturally competent healthcare was identified by Student Council, and they were represented by over 12,000 students who participated in legal residency and citizenship programs. And from there, we established La Maestra with, of course, Sara, our CEO. And the mission for La Maestra was to provide quality healthcare and education, improve the overall well-being of the family, bringing the underserved, ethnically diverse communities into the mainstream of our society through a very caring, effective, culturally and linguistically competent manner. And I'll share with you as we go on the slides about our culturally competent team which we have quite a bit of representation. And all of this in a manner respecting the dignity of all our patients. Next slide, please. Here is our circle of care where it encompasses all the services that we provide across the continuum of health. As a patient-centered medical home and through our model of care, we do the utmost to enhance health and the patient experience. This, of course, as you can see, all the services provided, and we also cover social determinants of health. As you can see, promoting lifestyle, food security and well-being, economic empowerment, safe and healthy housing, to include all our networking and collaboration, community development, advocacy, of course, and community promotions. As you can see here as well, we do a lot of women's health care on the primary care side. Pediatrics, we have quite a huge group of pediatricians, OBGYN, vision, adult care, family practice, and I'll go later on and discuss our specialty clinics. Next slide, please. These are our locations. So we have 22 licensed clinical sites, both medical, dental, school-based programs. Our Hope Clinic, which is an access point for our homeless population in San Diego communities. We are located from downtown San Diego, about 15 minutes in City Heights. Of course, about 20 minutes from here, El Cajon, which serves a lot of our Chaldean population, National City, a lot of our Hispanics, and Lemon Grove. We also provide services for behavioral and mental health via telehealth, WebEx, and Zoom. We are very proud of our digital imaging, our mammogram, as well as our mobile mammogram coach, which participates in health fairs and allows women who do not have access to mammograms to provide these services free of charge. So this works out very well. We do have a provider. She works very closely with the health fairs and community centers to take this bus and go out and provide the services. Next slide, please. So here we have serving why it's so important for us to serve the culturally diverse communities. Our center site is in a refugee resettlement area along the U.S.-Mexican border. We are right next to San Isidro. Our Mexican border is San Isidro with Tijuana. So we get a lot of the migrant population, as you all know. This is a port of entry. So we do get quite a bit of our population. And we do have staff also, which represents culture, very cultural, ensures cultural and linguistic competency in all our programs and services through cultural alignment and shared life experiences. In our clinics with our providers, anytime there's somebody who needs translation and all, we have the cultural liaisons come into the office and they do direct translation with our patients. So it's very effective. It works very well. And because they're very culturally sensitive, it's just an amazing opportunity to link very closely with the patient at their level. We do speak 60 languages and dialects spoken by 45,000 of our patients. And we've grown quite a bit to almost greater than 840 plus employees. The medically trained cultural liaisons provide medical interpretation, as I mentioned previously, patient navigation. They also help because they are involved in the community. They know a lot of our patients. So they are able to promote the health education and case management as well. We train, test, and certify our medically trained cultural liaisons. Next slide, please. Here, I'm very involved with the specialty clinics. Sorry about the clinics. I missed Anaya there. But I'm very involved, and you will see here the circle of care. So I'm going to go to the right. From our mobile clinic, we do the screening for new participants, the CDCR, Department of Corrections and Rehab, where one of our providers is there, and we capture patients that are being into a reentry program. And so those patients, we test them all, as you all know, for hepatitis B and C, HIV testing, and if positive, then we refer back to our hepatology clinic where we test and treat for hepatitis C. I am basically leading in that with one of our consultants, but some of our providers are also trained into treating hepatitis C. The movement is to have primary care treat for hepatitis C because it's curable. So that's really exciting when we have these patients, and basically they come and say, I wasn't treated back in the prison, but they're aware that the new treatments have been extremely effective, and cure rate is 94, 98% with 2 wonderful medications, so it works out very well. We also get referrals for hepatitis B, our huge population, African population with huge numbers of hepatitis B. We test them, treat them. There's currently, we cannot, it's not being, we treat continuously because there's no cure. Currently, there's no cure for hepatitis B. However, we monitor them because of their high risk for liver cancer and high risk for progression to hepatic failure. So we do a surveillance for these patients, and they are, we monitor with our case managers on surveillance every 6 months. The third component is we treat for alcohol use disorder complications. So those patients who have cirrhosis, we monitor them as well. And if they qualify, we will send them over for transplant to our closest university, which is UCSD. And touching on that, we have our addiction clinic where we have an addiction psychiatrist that deals with alcohol and addiction programs. So they start them on the program. We also have 2 psych nurses, which are psych nurse practitioners who also do prescribing. And also, as you can see, all the clinics touch each other at a very high level, and we work very closely, all of us. Next slide, please. This is on the right, you have our part of our HIV team, which works, our staff is culturally competent. They speak several languages. We promote HIV testing and education. We do hepatitis testing and STI testing as well. Distribution of education information in the community. They hand out HIV self-testing kits, case management of patients on PrEP services, our linkage to care for all our HIV positive patients through a program where we are linked with practice transformation with our Owens Clinic at UCSD. And we also collaborate with industry leaders in HIV services. On the right, we have some of our collaborative efforts. And one of them is Gilead. We work very closely with Gilead in providing the post-exposure prophylaxis and the kits and training. Part of the training is, the invitations for those nice dinners that we all get for training and having everybody involved in the HIV PrEP prevention. Next slide, please. So this HIV PrEP clinic started in September of 2020 with hiring a case manager. We began following patients that were currently on PrEP. The team started participating in health fairs, getting our name out in the community that we were providing these kinds of services. And we did receive 2 grants by HRSA and SAMHSA, allowing us to expand these services in our community and expand our team as well. And we also at that time had a collaborative effort with UCSD Owens Clinic on practice transformation. And one of their lead providers would come in almost every month and do some staff training on PrEP, HIV, and PEP, and also to be culturally sensitive to the population as well. Next slide, please. Again, this is part of our team promoting HIV, STI, and hepatitis testing, handing out kits, case management, and of course, anytime there is a need, we do the linkage to care for all the HIV positive patients. We're currently starting to treat HIV here at the clinic. And so we do have one provider that feels really comfortable. And then we have assessment from, we can always call in our specialists at UCSD to assist us in the treatment of our HIV patients. Next slide, please. Here we have an award. This Brad Truex Award was established to honor the memory of Dr. Brad Truex and recognize his significant contributions to the HIV/AIDS efforts in San Diego. This prestigious award is bestowed annually on World AIDS Day, December 1st, to commend individuals who have made outstanding overall contributions in the fight against the HIV/AIDS epidemic within our community. The award encompasses several categories, including HIV education, prevention, and/or counseling and testing, HIV care, treatment, and/or support services, HIV planning, advocacy, and/or policy development. We received this award in December the 1st, and this is a stepping stone in our HIV clinic since it's open because it allowed us to continue spreading awareness for HIV prevention and our services at La Maestra Community Health Center. We're extremely proud of this award that our team really worked very hard to get this one. Next slide. Thank you. Also would like to share some of our accomplishments. We have targeted hypertension, not pertaining to this talk, but we would like to share some of our accomplishments about in our adult medicine, accomplishing 70% of control rate for our hypertensive. And as you know, it's this way we are avoiding many of the complications and organ complications for these patients. Our next slide, please, is also part of our adult family medicine treatments that we provide for type 2 diabetes. We have a huge type 2 population, and we were also recognized because we were able to maintain our adherence to medication and our risk management, being able to decrease our cardiovascular focus clinical measures. So it's really, it's something we're extremely proud. It's also something that I work very closely with our primary care providers. Next slide. And this is also some of our health quality recognition badges from HRSA. And as you can see, I'm extremely proud of the work we do here at La Maestra. We work with many underserved populations, but the fact that we have all these cultural liaisons in our teams, it really helps us communicate at the level, medical level, and culture, and very sensitive to the culture. So with this, I close, and I'll wait for questions if you have questions at the end of the presentation. Thank you very much.
Thank you, Dr. Tessier, and thank you so much for your service and the service that you provide to the community in San Diego. It's really interesting to see all the services provided by La Maestra and the specialty clinics. I would like to stop for a moment and see whether there is any questions for Dr. Tessier at this moment, whether you would like to know more about the cultural liaisons that she mentioned, or all the community organizations working with La Maestra, and specifically addressing HIV. I saw a few of these organizations, and they provide culturally competent care. So at this moment, is there any questions for Dr. Tessier? Just keep remember that if you would like to ask a question, you can use the chat box, or you can also use the hand raise icon, and your line can be unmuted. Dr. Tessier, I do have a question for you, and this is related to the diversity of the population in San Diego. And one of the biggest concerns when we discuss cultural competency is the fact that in addition to the translation and the interpreters and all the services that we provide, we need to be very careful with the confidentiality issue, specifically when we have a condition that is so stigmatized in the society. What strategies do you teach, or what strategies the staff get, in order to make sure that in addition to be culturally sensitive, they also are, they respect the privacy of the patients?
Sure. Yes, we follow very strictly HIPAA regulations, and we train staff on it. So that's very important for us. And I think one of the things is that they do share, many of these patients share they come together in these communities. So it's very important that, like you say, that they keep their confidentiality. So we do some training on HIPAA very closely with them, and they are aware that, not sharing information and all is extremely important. Although at times it's difficult, it's quite difficult to control, but because they're kind of leaders in their community. And so I've had, for example, in our hepatology clinic, I've had them, one of the cultural liaisons is one of the leaders, and she kind of says, I know this person should be doing this and that, in terms of hepatology. And so they kind of scold them because they've been leaders in this community. So we try as much as we can to follow our HIPAA and remind them always about our HIPAA regulatory requirements.
Thank you so much. And there is a question from Darla Stewart as well. And the question is, what is the biggest barrier and how do you overcome that barrier when conducting outreach and care to the border immigration communities?
I think one of the barriers is people are afraid of their migratory status. And because we are not a policing agency, we reassure them that, we will keep their information private. But I think that's one of the main concerns. The rest, many times these patients come in without a lot of medical care. And so they come in, when they come in for their initial visit, we try and provide all the social services. We also have legal services as well. So we try and promote, as you can, reminding about the circle of care, we try and touch all of the aspects of their fears as well. And so once they come to a clinic, many times they're uncontrolled, but we do our best because most of our providers, we speak several languages. So it's very important for us to reassure them, telling them how important it is to get care, and just touch it, be available to them. And that's why at our mobile clinic, one of our providers who goes out there, she is very outgoing. She really pulls in the patients in, and the fear is gone. But most of the time, it's due to the migratory status.
Excellent. Thank you so much for that answer. And I have a follow-up question, Dr. Tessier. How do you offer HIV screening and STD screening for these communities? Sometimes it's a challenge. So can you please describe how you do it?
Sure. So for the screening, we usually screen in our primary care setting. Part of our hepatology protocol is to do all HIV screening, and all the providers do HIV screening within a certain age range. And then our OBGYN clinic as well for STDs. So when they go out in the community, we're getting some kits, and with those kits, they're able to do some of the, provide those kits for screening as well. But we do it as part of our primary care, of our preventive care module. Some of our migrant population, at times when we tell them that they will be screened for HIV, they have the right of refusal, and some of them, because of the stigma, do not want to be tested. So, we have to respect that, but most of the time we do it as part of our preventive care. For STIs, if there's any risk, then we will do the STI testing with, of course, authorization by the patient. Excellent. But the other ones, for hepatitis, across the board, there is it's a new thing about testing all patients for hepatitis C, because there's a lot of population. I think there's millions of people who are not aware that they have hepatitis C. So we do it across the board. It's not standard of care. So that's how we capture some of these patients. Mhm.
Perfect. Thank you so much for that information, and thank you so much for being with us and your presentation on the service that you provide to the community in San Diego County. Thank you so much.
Mhm. Thank you.
So before we continue, there are a couple of things that I would like to mention here. Probably I'm going to need the recipe for some of these food that I'm seeing here. I see the Persian gourmet sapsi, I guess, how do you pronounce it? Then I have carne asada. I have a spiced Brussels sprout salad with rice and beans. And the last one is, I'm gonna need this one, chicken quesadilla with mango salsa. Wow, that's amazing. Thank you for sharing that. So we are going to move on, and now we are going to hear from Lisa Rowinski. She is the project coordinator for the Deaf HIV program at the Deaf Community Advocacy Center. So thank you, Lisa, for being with us.
Hi, thank you so much for having me. My name is Lisa. My pronouns are she, her, and hers. And I'm here today to talk about cultural humility and destigmatizing HIV in the deaf community. I work for Deaf Community Advocacy Network, which is, we use the acronym DEF-CAN. And that's how people know us here in Southeastern Michigan. And next slide, please. So my credentials are, I have a master's degree in counseling. My NIC credential means that I'm I have a national interpreter certification. So I am nationally certified to interpret between American Sign Language and English. So I am fluent in American Sign Language, which helps me have be able to work directly with the clients that I serve. I am the project coordinator for the Deaf HIV program at Deaf Community Advocacy Center. And unlike the last organization we looked at that has 840 plus employees, we have 6 full-time employees, and 3 are deaf and 3 are hearing. All of us are bilingual, and we all communicate in American Sign Language and English. Next slide, please. So before you can develop cultural humility, one needs to know that there is a certain community that actually has a culture. And I'm not sure a lot of people, if you're not involved in the deaf community, are aware that the deaf community does have their own culture. Starting with the use of American Sign Language, communicating in a different language, emphasizing that American Sign Language is not English on the hands. It has completely different grammatical rules and structure and syntax as compared to English. So it is a very different language. There are deaf schools, CODAs, you see that word in the kind of mid-right side. That is an acronym for Children of Deaf Adults. So those are hearing people who are born to deaf parents, and their first native language is typically American Sign Language. There is a deaf art movement. There are deaf stories, deaf jokes. There are specific deaf values, behaviors. Deaf people feel very strongly about their identity and their history. I also would like to add at this point that I'm using the word deaf as an umbrella term to include deaf, deafblind, and hard of hearing individuals. So rather than saying all of that, which is quite a mouthful, every time I use the word deaf, I'm including all of those groups. Next slide, please. So deaf people living with HIV, it's right. We would wonder about that. So according to this statistic, there are about 11 million individuals in the United States with hearing loss, some sort of hearing loss, that are either hard of hearing or have profound hearing loss. Next slide, please. And how many of those deaf people are living with HIV? Another excellent question, especially for people who are working with deaf people living with HIV. Next slide, please. Your guess is as good as mine. There are absolutely no statistics that share or have researched or sought out that information, the overlap between deaf individuals and those living with HIV. Next slide, please. So the Center for Disease Control does not disaggregate HIV/AIDS prevalence rates on the basis of hearing loss or deafness, nor does anyone else, is basically what that top paragraph says. Next slide, please. Several studies do suggest that the HIV prevalence runs higher, specifically among persons who are deaf. And a number of authors have contended that persons who are deaf receive inadequate prevention information and treatment. Oftentimes, there are many, many, many reasons for that. Oftentimes, there are very strong cultural and linguistic barriers to deaf people accessing appropriate and current information about HIV. Next slide, please. I did come across one article that I can provide the link for this article. It's fairly new in terms of deaf HIV research from 2021, but I think the headline is the most telling. Deafness trumps HIV for deaf people living with HIV. So meaning this article, there was some research done in a specific area, and it was found that the challenges that deaf people had were greater than the challenges that deaf people had with HIV. So their deafness caused greater challenges than their HIV status did for them. Next slide, please. So I wanted to take a minute to that was all really fast. I was asked to speak for maybe 5 to 7 minutes, so I wanted to be mindful of people's time. But the takeaways that I would like to leave you with are as follows. The deaf community has its own culture. The deaf community has its own language, and it's not related to English. The deaf community does not have regular access to culturally and linguistically appropriate materials. Several studies suggest that the rates of HIV are higher in the deaf community than in other communities. Stigma is deeply rooted in the deaf community, often as a result of lack of accessibility to information about prevention and treatment in culturally and linguistically appropriate ways. To reduce stigma about HIV in the deaf community, information needs to be culturally and linguistically accessible, and a great deal of outreach and education needs to be put in place. A lot of brochures, a lot of written materials, you can find them in English. I know here in Michigan, you can find written materials in Spanish. You can find written materials in Arabic. There are not materials that are accessible in American Sign Language to deaf people about HIV and about living with HIV. So oftentimes they will perhaps get a diagnosis at an urgent care center. The doctor will hand them a brochure about living with HIV. The deaf person may try to read it, may ask for help reading it from a family member, oftentimes does not understand the content of the high register of English medical language, and really, really doesn't have an understanding of what that diagnosis means for them. Next slide, please. And here is my contact information. I know I spoke quickly. I had a few slides. It's a huge topic. There are entire college courses you can take about this topic, about deafness and what that all means living in a hearing world. But if there are any specific questions, I'm happy to listen now. But there is our website. There is my email address, my cell phone, and my text number, and then my video phone. For those who don't know, video phones, TTYs are usually what most people think of when deaf people communicate over the phone. TTYs are a thing of the past. They are ancient. They are not used any longer. Video phones are what deaf people use to communicate these days in American Sign Language. And I do have a video phone. If it rings, a deaf person is calling me. I push a button, they come up on the screen. We can communicate with each other through sign language. Much more smooth and much more technologically advanced as compared to TTY communication. So thank you so much for for asking me to present, for listening to my information. And I'm happy to entertain any questions if anyone has them and if I can answer them.
This is fantastic, Lisa. Thank you so much for sharing this information that is extremely, extremely useful for all of us. I was going over your slides early, and I found this extremely important. Sometimes we think about cultural competency. We think about racial and ethnic minorities. We think about the stigmatized groups like the LGBTQIA plus community, but we forget about our patients with disabilities, specifically the deaf community. So thank you so much for this, because this is going to bring some attention to those serving this population. So thank you. If you have questions for Lisa, please, let's follow the same mechanic. If you have any question, you can type your question in the chat, or your line can be unmuted if you use the hand raise icon. So Lisa, question, there is a comment here, Lisa. It says there is probably a dearth of ASL resources on healthcare related topics, but do you have any that you recommend even outside of HIV?
Yes, I was asked that before we kind of went on, before the session started. And again, it's so hit or miss, the research that's being done. I wouldn't even know where to start. I can work on putting together a resource list. I guess my major goal, or the thing that I would want you to take away from this, though, is that unfortunately, despite the Americans with Disabilities Act mandating effective communication between doctors and patients, between medical providers and deaf patients, many medical providers still refuse to provide American Sign Language interpreters to their patients. And it seems to me, it's the year 2024. I find it almost unbelievable, but I will tell you that even as of last week, I was advocating for a deaf client to have a sign language interpreter at their doctor's appointment. So it is still very prevalent that deaf individuals are not receiving the accessibility that they are guaranteed under the Americans with Disabilities Act. So I guess my biggest, thing that I would want you to know is that if a deaf patient gets in touch with you and says, I need a sign language interpreter, a lot of times the office says, we don't do that, or we don't have that. Somewhere where you live, there is an interpreting agency that will send a sign language interpreter to your office to interpret that medical appointment. It will cost you money, but it's mandated under the law, under the federal law, that you provide that accommodation to your deaf patients.
Thank you, Lisa. That is very important information. And we have two questions here in the chat, and Vanessa is asking the question that I was going to ask you, so I'm going to read it. And the question is, I'm sorry, let me go back to the question from Darla. That is the question that I was going to ask you. Can you use American Sign Language to support those who are deaf and non-English speakers? or speak who don't speak English?
That's a good question. American Sign Language or sign language in general is not universal. So each country has its own sign language. So there's French Sign Language, there's British Sign Language. So American Sign Language to English is like how I interpret. And at times we can find trilingual interpreters who speak English, Spanish, and American Sign Language. And at times that's something that's very necessary. But no, if you're looking for, if I think I understand your question, if you're looking for someone who's deaf, communicates in sign language, I would only be able to interpret that into English, not into another language.
There is a comment here. It says, depends on if they know ASL or a different sign language. There are many, so interpreters are trilingual and interpret English, Spanish, ASL, or other combination.
Yes, correct.
So
Thank you.
there is another question here in terms of the video phone. How do you go about patient privacy compliance? How does the patient have to sign any document before calling?
No, and that's a great question. I'm so glad someone brought that up because there are problems with people not wanting to share confidential information over a video phone because there is a third party. Actually, a video relay interpreter is not considered a third party. It's considered an accommodation under the ADA. But sign language interpreters, including video relay interpreters, have a very strong code of ethics that we must abide by. And so there's no concern about confidentiality. I have worked as a video relay interpreter. I have made, facilitated calls to banks, doctors' offices. I've gotten credit card numbers day in, day out, dates of birth, HIV status, anything and everything. So it's all completely confidential. We're in the office that we're in is federally mandated by the FCC to have 2 locked doors between the working floor and the outside. And confidentiality is our number one most important thing that we walk in our booth, we put our headset on, and then we leave it all behind us. So no, it's all considered confidential. No, nothing needs to be signed.
Thank you, Lisa. And I think that somehow you have touched this topic, but if you could expand a little bit, there is another question in the chat that says, can you speak at all to the differences between in-person ASL interpretation and a virtual interpreter on a language line?
Yeah, so we call that VRI, video remote interpreting, and there are a lot of health systems that are trying to move towards that system. So basically, instead of having a deaf person go to a doctor's appointment with a physical interpreter like me walking into the office, the deaf person will be in the doctor's office, and someone will roll in a cart with an iPad on it, and there's an interpreter on a 2-dimensional screen, interpreting for the appointment. Deaf people in general, I'm not speaking for all deaf people, the deaf people I know and the deaf people whose comments I read online in general are not fans of video relay interpreting or video remote interpreting because it's all based on a Wi-Fi connection. The Wi-Fi connection can be good or bad inside a doctor's office. Lots of times the interpreter will freeze, the picture will pixelate, the interpreter moves slowly, and there's just like non-effective communication. So the law is to provide effective communication. Oftentimes a patient will request an in-person interpreter. The doctor's office will refuse and will provide a video remote interpreter, someone on an iPad, and it can get a little dicey. medical provider's responsibility is to provide effective communication. And if the deaf person is saying an interpreter on an iPad is not effective communication for me, then typically the medical provider should listen and request an in-person interpreter next time.
Excellent. Thank you so much for your participation and your answers and for bringing this topic up. I mean, this is something that many health centers are interested in, and this is your contact information in case somebody would like to follow up with you and
Yep,
see what
absolutely.
resources you can offer to them. So thank you so much. And I have a question, Dr. Tessier. I'm not sure if you are still with us, but
Yes, I am.
this is a follow-up question regarding Lisa's presentation. So how do you prepare or how does La Maestra prepare when you have a patient who is deaf and is looking for health services as La Maestra?
Yes, I think usually we call the health plan, and they provide those kinds of services. So because we are contracted with most of our managed health plans. So we do call the health plan, and many times they will send over an interpreter based on the health plan that we requested from. Mm-hmm.
Excellent. Thank you so much.
You're
So
welcome.
Fide, we can go to the next slides, but can we go to the true or false exercises that we have, see whether we can keep doing our presentation where we left off, I guess. It is at the end.
One moment, let me jump into the slide deck right away. Should be towards the end. Okay. Let me share my screen.
Can you move to the true or false, Fide, please? We are going to go over the case studies in our next session. Do you have those? I think that they may be up to one of the previous slides that you had.
One moment.
We've heard from two really great speakers today, providing different information about cultural competence and HIV patients. I am very impressed, and the information that we received is I know that is going to be very useful for all of you guys. So thank you so much for that. So I think is the one below that one here. No, so probably it's not there. So let's move to the case study. Okay, sorry. So let's do a case study. We only have 6 more minutes to go, and we have a lot of material to cover in our next session. We keep working on some basics on how we can help our patients and how we can address cultural competency, as well as we are going to start our discussion on some of the minority populations. We are going to talk on cultural competency and the Hispanic population, the need to provide HIV services, health services to our patients. But in the meantime, this is a case study, and this is something that we can have, that we can use exactly the same, either the chat or or your line can be also unmuted if you want to participate verbally. But let's do this and go over this case study. Sarah is a 30-year-old sex worker. One day she went to a health facility for an STI check and a supply of condoms. When she arrived at the health facility, she was kept waiting for a long time. Clients who arrived after her were treated before her. When she asked one nurse for help, the nurse said, "You'll just have to wait. We know you, ladies of the night. You wait all night for men, so why can't you wait a few more minutes?" The nurse said this in the presence of the other clients, and Sarah felt humiliated. So this is the description. If you participated in our last session, we had the picture and the little cartoon where we had specifically this situation. And so for all of you, what is wrong with the nurse? What she's doing wrong, and what does she need to know about cultural competency? So any comments, please, we can use either the chat box, or your line can also be unmuted.
We just received a response in the chat, Dr. Neal, by
Okay.
Adriana saying HIPAA.
Okay. So we've been discussing about the need to provide cultural competency training to our staff, making sure that not only the clinicians, but everybody who is working in the clinic have the information that they need to be cautious and work with any type of patient, regardless of how the patient look or what the patient do. In this case, we see that there is a nurse who has not received any training. That's my opinion. And there is also she's stigmatizing this person. So I see some comments in the chat. Fide, can you please go over the comments?
Sure, yeah. We have one response by Michael saying no objectivity in her care. She violated HIPAA and fed external stigma, promoting internal stigma. Then another response by Susan, discrimination. She openly humiliated a patient based on her professional situation, which is definitely inexcusable. And then by Darna Stewart, the nurse needs to be retrained to recognize how their own bias impacts how they treat the patients. Another response by Crystal, the nurse is being very judgmental. This makes the patient feel ashamed and she most likely did not receive treatment. Another response by Dion, the nurse was highly disrespectful and dehumanizing. Another response by Zachary, it's a deeply stigmatizing thing to say. And this is so unprofessional, perpetuates stigma, and very unprofessional and discriminating.
And thank you, Fide. And we still have 1 more minute. The follow-up question is, how would you help your colleague here? What recommendations would you give to this person, to this nurse, so she is more culturally sensitive? We heard different situations, and we also listened from Dr. Tessier about the need to provide training to all the staff, new staff, and sometimes we need to reinforce this training to the people, to all the staff who, regardless of whether or not they are new or not, they need to work with patients, and so they avoid to this issue to stigmatize patient. But we have a response from Crystal. Peter, please go ahead.
Yeah. Crystal mentioned she should have shown professionalism and respect for the patient. She should have training on cultural communication. Another response by Zachary, assuming her profession from her lifestyle, using euphemisms is both unprofessional and disrespectful, making her wait longer for care and discrimination, disrespecting patients verbally, saying it in front of other patients breaches confidentiality. Yes, that was for the first question, Zachary, but thank you so much for providing your response. We do have another response by Sarah. It says remind them to the purpose of the job, and it is to help and support people medically. And we want to promote patients sharing information with us, in this case, her profession, so we can properly screen and support patients and their health. And then another response by Adriana, giving value to the uniqueness of each culture in the community and do not regard one culture to be superior or worse, right or wrong.
Excellent. Now, those questions are right. And thank you so much for participating in this session. I would like to especially thank Lisa Rowinski and Dr. Adla Tessier for their participation. And next week, next Wednesday, we will have another session similar to this one. So thank you so much for participating. We are going to have interactive activities. So please make sure that you come and attend this. And for this one, thank you so much for participating, and see you next week.
Yeah.
Thank you. Have a
Thank
great
you.
afternoon.
I did wanted to remind everyone to please complete our post-evaluation survey as you exit the session. And please let us know if you would be interested in getting a certificate for attendance for